So thank you very much for your kind introduction, and good afternoon, everyone. So on behalf of Dr. Lupa Singer and co-authors, so it's my great pleasure to present our study on the metabolic dysfunction-associated steatotic liver disease, or MASLD, among people with HIV in the Asia Pacific. So here is my disclosure. So just go quickly. So with the new term of fatty liver disease, as you can see here, so we call steatotic liver disease now, and NAFLD has changed to MASLD, and then so for this study we focus on MASLD and metabolic dysfunction associated steatohepatitis, or MASH. So in the past we called NASH, so now we move to MASH. So the MASLD, so is one of entity of steatotic liver disease combined with at least one out of 5 cardiometabolic criteria. So it's shown here, and without other causes of steatotic liver disease. So with that, so it's from the spectrum is from simple steatosis to MASH, or metabolic associated steatohepatitis. And with that, so when the patient develops MASH, so it can progress to cirrhosis and liver cancer. So these are the factors related, but I would like to include the people with HIV into the factor associated with MASLD progression. So why we do this study? Why we analyze this study? Because of the MASLD, or the steatotic liver disease, is rapidly increasing, and it's also challenging in HIV care. So as you can see here, so the MASLD affects about 30% to 60% of our population, and progress more rapidly than in general population. As you can see here, that for the steatohepatitis is also at least 3 times higher than general population. For some study, you can see that. So it's almost 50% from liver biopsy show the show the MASH, and so the risk of cirrhosis is also double of general population. So beyond liver-related complication, so MASLD also elevates cardiovascular risk, fatality, and mortality. And it is often associated with obesity, diabetes, metabolic complication. So all these also are higher in our HIV population. And not just higher, the prevalence higher, is also occur at the earliest age. So, however, little is known regarding the risk factor and complication of MASLD. And we aim to identify the prevalence of MASLD and among people with HIV in Treat Asia HIV Observational Database Continuum of Care, or we call THAHOT-CC here. So we include the people with HIV from all the countries in the THAHOT-CC, from, as I don't know, you can see here, from Japan, South Korea, Taiwan, Hong Kong, Philippines, Vietnam, Cambodia, Thailand, India, Malaysia, and Singapore, and Indonesia, so all the countries. So, so we collected the data during the 2010 to 2023, and so the definition of MASLD, we use the definition. We use the hepatic steatosis index score greater than 36. So using very simple formulation with the ACLT, BMI, and also evidence of diabetes or not. We use the non-invasive test to evaluate steatohepatitis using FIB4 and APRIs. So because of the good negative predictive value for rule out fibrosis, and also the calculator freely available on the internet. So we include people 18 and older and without excessive alcohol use. And also they have to be on ART, had ALT/AST, height, weight, and glucose for analyze. So the endpoint here is prevalence of muscle, proportion of those even with chronic kidney disease, defined as CKD EPI less than 60, and also proportion of those with MASH by the FIFO greater than 2.7 and API greater than 1.5. Almost 66,000 in a patient in Thailand CC. So we included 9,052 patients in the analysis. So almost 50% of the patients had a muscle, as you can see here. And so baseline characteristics between the two groups were not different. So in general, so they were about 36 years old, and 30% were female. And BMI, as you can see here, the BMI was very low at the ART initiation. And almost 52% they were from high-income country. So hepatitis B, hepatitis C, about 12%. And so at the time, the most ARV regimen was equivalent-based regimen, followed by the PI and instant regimen. The proportion of those ever with the CKD, so it was the same between group, is about 15%. So look at the proportion of those with MASH or steatohepatitis. On the left-hand side, it's about API, and on the right-hand side is a FIFO. So you can see here, so the significant liver fibrosis is almost 40% by API, and almost 30% by FIFO. And advanced liver fibrosis is 8 to 11%. So if we follow the European guideline, so from these patients, we need to intensify management of comorbidity and also follow up with the FIFO score. So look at the trend in proportion of muscle by country income. The red line represents low income, blue line with the high income, and the green line with the upper middle income. So from 2010, so the muscle rate increased from 28% to 35% in 2023. So the increase was observed in both low and high income, but for the upper middle income, so it's stable high at 35%. We see that for the muscle, is associated with the BMI greater than 23, hepatitis B, hepatitis C, or hepatitis C co-infection, high cholesterol, and even smoke. So when we look at the impact of lifestyle-induced weight loss on liver histology, so this is a future target therapy that we should discuss with the patient. So it can be reversed with significant weight loss, especially if weight loss greater than 10%. So fibrosis regression can be seen. So I would like to summarize that the muscle is highly prevalent among our population. And it's very important not just look at the prevalence, we should look at hepatosteatosis or MASH with advanced hepatic fibrosis, because this can quickly progress to cirrhosis and hepatocarcinoma. The higher proportion among those with higher BMI, elevated cholesterol, viral co-infection, and history of smoking, so highlight the need for ongoing screening, monitoring, and targeted intervention. So what we can do, like a lifestyle modification, optimize lipid profile, and reduce systemic inflammation, as shown by repeat study using statin, and also GLP-1 agonist by A5371 study. So further study on long-term outcome of muscle on metabolic syndrome, ASVD, cirrhosis, and cancer should be possessed. And so just would like to acknowledge the Thailand CC is an initiative of Treat Asia, a program of AMFA. So the director is maybe in this room also, and with the Kirby team. And all the Thailand CC study member. And finally, just like to ask everyone that whether should people with HIV be screened for liver fibrosis based on high hepatitis co-infection in the region. Weight gain related to and TAP use and metabolic complication, ongoing inflammation. So even though the previous study, the previous speaker said that, oh, it seems like the prevalence is declining, but I think, so maybe we use, because of use integrase inhibitor, so weight gain, we will see that. And also the rapid liver fibrosis. So thank you very much.
Yeah.